So I'm Alex Wong. I'm an infectious disease physician in Regina, and I want to welcome all of you to the Saturday Lunch Symposium, sponsored by Merck. So I'll be moderating and presenting some of the material along with my colleagues, Bertrand Lebouché from Montreal and Kate Squires from Merck Research Labs. And we're going to talk a little bit about some of the various drugs that we currently have in our arsenal for antiretroviral therapy and take a look at the pipeline sort of going forward. So thank you to all of you for attending today. Have slides, please. So kudos to Merck for putting this picture up. Really another NNRTI and a computer that I remember using probably when I was in maybe grade 1 or grade 2 to give you a sense of how old I am. So the talk's entitled, as I said, really another NNRTI, Research in HIV, a Lifelong Journey. And I want to begin just with our land acknowledgement. We acknowledge that we are gathering on Treaty 6 territory and the homeland of the Métis. Recognizing this history to our future and our efforts, is important to our future and our efforts to close the gap in health outcomes between persons who are of Indigenous and non-Indigenous heritage, and we pay our respects to the traditional caretakers of this land. So as mentioned, the objectives of the symposium over the course of the next hour plus is to talk a little bit about the value of another NNRTI to HIV management, to talk about some cases that might be relevant for doravirine specifically in our day-to-day sort of clinical lives, and to talk a little bit about what's in development and to look at the evolution of HIV management in the future. So I'm going to begin by providing a bit of an overview of doravirine, which is the new sort of NNRTI on the block. These are my conflicts of interests and disclosures. So let's start by talking a bit about NNRTIs. So for those of us who are involved in the clinical space, we're all familiar with the fact that there are NNRTIs that have been around for quite a long time. And currently, the ones that we're probably most familiar with are efavirenz and rilpivirine. They're used most extensively in clinical practice. And then we have another agent called etravirine or etravirine, which is used mostly in individuals that are treatment experienced. So I'm going to just very briefly talk from a clinical perspective about each of these and the strengths and some of the drawbacks. Efavirenz has been around for a long time, and it is a great drug. It has excellent potency, durability, and a 20-plus track year history of never actually being beaten from a virologic perspective head-to-head in any clinical trial. Atripla is a term that almost all of you are probably familiar with. In July of 2006, it's historic because it became the first HIV single-tablet regimen available. But efavirenz has some drawbacks. There's the potential for CNS toxicity, increased transaminases, and hepatotoxicity. There were historically pregnancy concerns, which is actually no longer the case. There's the issue with efavirenz rash, dyslipidemia, and the so-called concept of low genetic barrier. For those of you who are perhaps not clinical, this refers to the concept of how sturdy a regimen is in regards to its development of resistance. And so a regimen that has a low genetic barrier is more likely to potentially develop resistance, whereas a regimen that has a high genetic barrier, despite perhaps suboptimal adherence, it's more difficult to develop resistance. So rilpivirine is sort of the next agent that came along. It's currently co-formulated with both tenofovir FTC as well as Tafin FTC, both for naive and experienced individuals, and with dolutegravir in the context of patients for switch. It's also available on its own. It's got excellent tolerability. It has a better lipid and CNS profile compared to efavirenz, but it also has drawbacks. The main ones are the fact that there are a lot of drug-drug interactions, specifically with proton pump inhibitors and acid-reducing medications. It requires food for optimal absorption, so food security can sometimes be very relevant. And it still has a lower genetic barrier relative to integrases, as well as concerns regarding potency and some hesitancy regarding its use in naive individuals with viral loads greater than 100,000. So etravirine or etravirine is used mostly in persons who are treatment experienced, who have some degree of underlying resistance. It's well tolerated, but again, it has to be given twice daily. There's lots of potential drug-drug interactions. There's potentially a severe rash. So all of these have strengths and weaknesses. So, the current paradigm for HIV therapy is really one that's driven largely by integrase inhibitors. And so, again, if you look at all the current guidelines, you're going to see that everything is sort of anchored by an integrase. So the current integrases, so raltegravir, elvitegravir, dolutegravir, and bictegravir, are basically comparable or better than, I would argue, any of the agents that I just talked about, efavirenz, rilpivirine, and etravirine, with respect to pretty much almost everything: dosing, tolerability, toxicity, the potential for drug interactions, and then this genetic barrier component as well. So, are there any criticisms in regards to integrase inhibitors? I mean, there's been some questions raised about the potential for possible weight gain. I think there's still a lot of conflict in regards to whether that's the case or not. There's obviously this issue with dolutegravir at conception and the potential for neural tube defects. And then occasionally there's been rare issues with CNS toxicity. And then there's a co-formulation issue, like something like bictegravir or elvitegravir is only available in a co-formulated manner. It's not necessarily a standalone product that you can use at this time. So the question really sort of becomes, do we even need another NNRTI? I mean, the integrases are obviously excellent. And so I would argue that having options at the end of the day is always going to be a good thing, especially for individuals that are more treatment experienced and for individuals that may potentially have developed resistance over time. And possibly for modernizing individuals who are still on efavirenz or rilpivirine-based regimens and who are doing very well and otherwise quite happy with that. So with all that said, so here's some other justifications, possibly simplification for those on etravirine, and possibly even cost-saving strategies for developing world settings. So with all that said, I'm just going to talk briefly about doravirine and sort of provide a bit of the background. Most of you, I actually wasn't entirely aware that doravirine was actually developed in Canada. It was actually developed in Montreal at Merck Research Labs, and so it's a Canadian achievement. It's the next generation NNRTI. That has a unique resistance profile. It's active against the majority of resistance mutations that we see with the first generation NNRTIs. It's dosed once daily. There's no food requirement. There's a very low potential for drug-drug interactions compared to the other NNRTIs that we mentioned, including with acid-reducing medications like proton pump inhibitors. And it's been approved in the US as of August of 2018, and it's been approved here in Canada by Health Canada as of October of 2018. So it takes away a lot of the concerns that we have with the various NNRTIs that were described initially. So I'm just going to dive right in and just kind of talk a little bit about some of the phase 3 data. I didn't want this to just be like nonstop data heavy, but I think it's important for everyone to at least understand some of the evidence underpinning the indications for doravirine and for single tablet doravirine as well. So Drive Forward was a phase 3 study basically comparing doravirine versus boosted darunavir, and it was placebo-controlled, double-blind, and so this was quite an undertaking. It was basically 4 pills plus the NRTI backbone, and so again, the entry criteria are relatively straightforward. And I'm just also going to describe the other large phase 3 study which occurred in parallel, was called DriveAhead. Again, this one utilized doravirine as a single tablet plus placebo and compared it against efavirenz FTC TDF, which is a tripla plus placebo, so again in a double-blind randomized controlled fashion. So the comparators were a tripla and boosted darunavir. Some of this had to do in regards to timing. The development program began in like 2012, 2013, and at the time, those were really our standards of care. And again, the entry criteria are very similar and quite standard. So just looking specifically at the 48-week data to understand the efficacy of the product, with Drive Forward, you can see here that there was 84% for the doravirine arm versus 80% for the boosted darunavir arm, again indicating non-inferiority in terms of efficacy at 48 weeks. And similarly, looking at Drive Ahead, comparing single tablet doravirine versus a tripla at 48 weeks, 84% versus 81%, again, so showing non-inferiority at week 48. So it works, and it's non-inferior and comparable to both PI as well as efavirenz. So there is 96-week data for both of these studies that was presented last year, and so very quickly just sort of looking at it, you can see that at 96 weeks, looking at the number of individuals with a viral load less than 50, still a higher proportion of individuals on doravirine versus boosted PI, 73.1% versus 66%. This is technically, statistically significant. The numbers may look quite low. Remember again to some degree that there was quite a significant pill burden here and attrition, as one would expect, perhaps over a 96-week trial. And so looking at some of the metabolic pieces, there's appears to be a much more favorable lipid profile with doravirine versus that of boosted protease inhibitor. Doravirine appears at least to be lipid neutral versus a PI, which as we know promotes dyslipidemia. So similarly with driveahead, which is the comparison with Atripla, again we see that the single tablet doravirine arm was non-inferior, 77.5% versus 73.6% at 96 weeks, which was not quite statistically significant. And again, looking at neuropsychiatric side effects for Atripla, which we know are very, very prevalent, there was a much lower prevalence of neuropsychiatric AEs in the doravirine arm versus the Atripla arm. Lastly, looking at lipids, again, we know that efavirenz promotes dyslipidemia, and so that's kind of what we saw in this study. But when you look at doravirine, it also appeared to be lipid neutral, at least. So this is a little bit more complicated, and so I'm just going to take maybe like a couple minutes to try to explain it through. Essentially, this is trying to summarize the resistance data in the phase 3 studies, and so what we have on the left is the cumulative number of patients who are on doravirine. So about 750 patients in the two studies on doravirine, and then the middle column you see those on boosted PI, and the column on the right you see are the patients who are on Atripla. So I'm really going to just focus sort of on the bottom, the numbers sort of in the bottom here, looking at primary NNRTI resistance and primary NRTI resistance. These are the numbers of individuals who actually developed resistance either to the NNRTI component or to the NRTI component in the study. So when we look at doravirine, we see a total of 7 individuals who developed NNRTI resistance in the entire program, 6 individuals who developed resistance to backbone. Then when you look at the middle column here, basically with boosted protease inhibitor, again, we know that boosted protease inhibitors have a very high genetic barrier of resistance. So not surprisingly, in that particular column, we see no individuals who develop resistance either to protease inhibitor or backbone. And then when you look at the Atripla arm, again, you see here that 12 individuals developed NNRTI resistance, 5 developed backbone resistance, and so this was at a slightly higher incidence rate compared to doravirine. So again, doravirine's not infallible. There was a little bit of resistance, but this appeared to be more robust than the genetic barrier that we see with efavirenz. This again is complicated, and it's a lot of numbers, so a lot of people will just kind of gloss through this. All I would say that we wanted to sort of emphasize here was that doravirine has a specific pathway which mediates resistance, and the most common mutations that we see are at positions 106 and positions 227. All this means essentially is that when we see mutants that develop resistance with doravirine, that the other NNRTIs, specifically efavirenz, maintain activity or a reasonable amount of activity. So you don't see anywhere near the same sort of level of fold change which indicates resistance with doravirine versus something like efavirenz. I think one of the paradigms that a lot of us who have kind of grown up and learned about antiretroviral therapy have always had is this idea that if you give someone an NNRTI and they develop resistance, then you sort of lose the class, so to speak. And the reason why I wanted to leave this up is just to show that with doravirine, I mean, you can get resistance, but if you do get resistance, you do maintain some activity with the other members of the class. Not to imply that you necessarily are going to stick with the class, but it's actually an option, as opposed to if you lose an efavirenz, if you lose with efavirenz, then you have lost, all of the first generation NNRTIs. So to summarize, again, relatively low rates of resistance to doravirine actually developed in these large phase 3 studies. and then it has a unique resistance pathway, sort of like mediated by 106 and 227 substitutions, as opposed to the traditional NNRTI substitutions that we're more familiar with, like K103N and so forth. And as I mentioned, in the patients who developed resistance with doravirine in the phase 3 program, there is still activity with some of the other NNRTIs that are retained. And actually, just as a interesting little side point, those that have this kind of 227C mutation actually appear to actually be hypersusceptible, meaning that some of the backbone medications we use, like tenofovir and 3TC, are actually more active rather than not. So with all that said, I'm just going to sort of take a quick look here at time. We're going to just kind of briefly go through a couple of additional studies just to sort of highlight how doravirine can be used clinically. The first one is a study called DriveBeyond. It's kind of near to my heart because we were able to contribute a couple patients from Saskatchewan into this international study. This was a simple open label study. It was one arm open label, basically using single tablet doravirine 3TC TDF in treatment naive individuals who had transmitted drug resistance with one of 3 mutations. So for the clinicians, it was a K103N, a Y181C, or a G190A. These are the most prevalent sort of NNRTI mutations that we see in individuals who have had previous experience with the first generation NNRTIs. There was a futility analysis planned early on to ensure that we weren't necessarily doing anything harmful to patients, but there was a lot of in vitro data beforehand showing good activity with doravirine versus these common mutations. So to make a long story short, it was a tough study to recruit. It was initially planned to recruit 60 patients in. And I think it was just difficult to recruit. This was it was a global study, so there were sites across the entire world, Europe, North America, and after 2+ years, we were only able to recruit 10 individuals into the study. So just looking at some of the baseline demographics, most of the individuals in question that were recruited had a viral load less than 100,000, and you can see just in terms of what mutations they had at baseline, 8 had the K103N mutation, and 2 had this G190A mutation. So what did we find? Basically, as mentioned, there were 10 patients recruited in total, and the study was stopped prematurely because it wasn't believed that it was going to be feasible to recruit 60 patients in a reasonable amount of time. But looking at what happened with these 10 individuals, basically everybody fully suppressed. 2 individuals had to discontinue prior to week 48, which was the primary endpoint. 1 individual discontinued basically due to non-adherence to medication, had a viral rebound, and then nearly resuppressed, but didn't quite get there, but then subsequently suppressed thereafter. And then 1 participant just was lost to follow-up at week 16, but at that time had already suppressed their virus. 8 individuals actually got to week 48, and all of those individuals in question achieved a fully suppressed HIV viral load. So this was obviously a small study with a small number of patients, but at least is a proof of concept and some clinical data to show that this regimen has activity in individuals with at least K103N, and the numbers with G190A were modest, but again, they did suppress. The drug was well tolerated. There was no discontinuations due to AEs. So the last piece of data that I just kind of want to mention is a switch study, and that essentially provides the evidence base for doravirine's current label, which can be used in both switch as well as in naive individuals. This was called DriveShift, and the 48-week data was presented last year. This was, again, sort of a standard switch study. There's a little bit of quirkiness behind it that I'll explain briefly. It was a 2-to-1 randomization. 447 patients were put into an immediate switch arm where they were put immediately onto single tablet doravirine versus a so-called delayed switch group, which was the comparator group, where the individuals randomized to the delayed switch group basically had their baseline antiretroviral therapy continued for 24 weeks. And that was the primary endpoint, which was considered for baseline ART, and this was compared to the immediate switch group at week 48. At week 24, those who were randomized to continue on their baseline antiretroviral therapy were switched then to single tablet doravirine and moved forward in the study accordingly. I'm not going to go through all of this. The only reason why I wanted to put up some of the inclusion criteria was just for the clinicians and for those in the room who care, looking at what regimens people were actually switching from. So you can see here that initially the plan was to actually switch to boosted PI, and I think later they allowed for individuals to switch from a COBE boosted integrase, so that would be elvitegravir, or an NNRTI like the ones listed there. So again, the study I believe started in 2013 or 2014, and that's kind of what was available at that time as opposed to some of the newer agents. So looking at the efficacy analysis at week 24, this is just week 24 data comparing baseline antiretroviral therapy versus doravirine single tablet. You can see on the left in terms of virologic efficacy that there is essentially no difference, 93.7 versus 94.6. And then the middle column was the number of individuals with virologic blips or failure, and that number was extremely low. So that was at week 24. And then looking at the primary efficacy analysis, again, this was the immediate arm at week 48 versus the baseline arm at week 24. What we see here in the green is the doravirine sort of 3TC TDF single tablet at week 48 was 90.8 versus 94.6 for current antiretroviral therapy. Some of this might have been mediated, again, by the fact that this was just a timing issue, the fact that we were comparing one group at 24 weeks versus another group at 48 weeks. Again, the number of individuals that had virologic failure in the middle column was extremely low. Drug resistance, basically nobody developed drug resistance, and the main reason why I wanted to leave this slide up was, again, looking here, there were 24 patients who were switched who had previously had baseline NNRTIs resistance documented, and they all remained suppressed during the course of the study. So a little bit of evidence continuing to support its use in individuals that have baseline NNRTI resistance. So with all that said, I think we've kind of gone through the data. There's two well-powered phase 3 studies looking at treatment-naive individuals and comparing it and showing it to be non-inferior in individuals basically versus boosted darunavir as well as efavirenz. And then obviously we have a large phase 3 switch study that shows non-inferiority and a phase 2 study which shows some reasonable activity in patients with baseline resistance. So that was just like super data heavy. So now what we're going to do is we're going to ask the question, so where and when might you consider using this in your patients? We're going to have Dr. Lebouché from McGill University talk about some cases and go through some of the more practical aspects of doravirine in the day-to-day clinical setting.
Bonjour à tous. Je vais parler quelques mots en français pour les nombreux francophones qui sont ici. Juste pour remercier Alex Wong de m'avoir invité à présenter mon point de vue de clinicien sur la doravirine. Aussi remercier Merck et remercier ceux qui organisent la conférence CAHR. So yes, I'm Bertrand Lebouché. I'm clinician scientist and family physician in the chronic virus services in Montreal, in McGill University. So my deal today is to present my perspective as a clinician, how I will use, or how I use actually doravirine. So here you have a slide of my, the declaration of my possible conflict of interest. So my current needs as a clinician, because I think there is always room for improvement. So why do I need new drugs actually? I need new drugs because we have still side effects with current therapy, and we have the risk of long-term toxicity with antiretroviral therapy. And for my patient, it's still a major concern. I have also to deal with resistance. I have patients with a heavy antiretroviral history, and they have some resistance. Also, Alex discussed briefly before, we have actually concern with possible weight gain with integrase inhibitor, and it seems that the other family, NNRTI, should be a bit away from this problem. And we need possibly a need for less drugs with dual therapy, or possibly we need less frequent doses with long-acting therapy. And also, why do I need new NNRTI? Because actually, with NNRTI, we have a problem of toxicity sometimes, and we can be better in tolerability. because I want to have a new NNRTI which could be active against common resistance to actual NNRTI. I want to have fewer drug-drug interaction. I want to have an alternative to integrase inhibitor and also to avoid the food effect. So what were the NNRTI accomplishments before doravirine? So Alex developed a bit this part. What we have sometimes low barrier to resistance. We have neuropsychiatric adverse effect, particularly with efavirenz. We have a problem of not using some of NNRTI when you have high viral load or low CD4. Rilpivirine must be taken with a meal. We have limpy decrease with efavirenz and drug-drug interaction. So, of course, it would be great to have something different in this class. And what is interesting also, that finally, the superiority we have with integrase inhibitor is not a virologic superiority when we compare with efavirenz-based regimen, is more a tolerability, superiority of tolerability. And you can see with this data of a single study, we were presented by Sharon Wamsley a few years ago. What was interesting when you compare in naive patient dolutegravir-based regimen with abacavir 3TC and efavirenz TDF FTC, you have a superiority in virologic efficacy at 48 weeks. But when you check, you have more discontinuation due to adverse effect in the atripla arm than the dolutegravir abacavir 3TC arm, and it's explained this superiority. And what is interesting also, that we have, I will show just after, there is a meta-analysis. We show us that finally there is not a major difference between protease inhibitor regimen and NNRTI regimen, particularly with efavirenz. And the last point is finally with NNRTI, they are relatively safe, quite safe for the fetus during conception and pregnancy, and it's more for efavirenz. So in this class of NNRTI, you have a new member, doravirine. So it's like a novel reinvented NNRTI with a unique resistance profile. Alex discussed that just before. And what is interesting is not a cytochrome inducer or inhibitor. So it's relatively neutral. And what is interesting also with doravirine, it's one daily dosing, and you can take it without regard of food. So I just put this data we were presented during the last CROI this year. They pulled the data from Drive Forward and driveahead. Alex discussed this data with you before. And what is interesting that for naive patients, finally, you have almost the same efficacy between a doravirine-based regimen with darunavir boosted-based regimen and efavirenz-based regimen. So I want just to show you what is my current use of doravirine actually in my unit with my colleague in the chronic viral services. So I just select two cases, two recent cases. So the first case is like first-line switch in the context of polypharmacy. So my patient was diagnosed in 2007, and he is actually under efavirenz TDF FTC. And he needs to switch for 3 reasons. He complained of progressive loss of energy, fatigue, decrease of concentration, abnormal dreams. But it's not clear exactly what is the reason of that. Is it linked or not with efavirenz is not so clear. But also he has a possible interaction with rivaroxaban, his anticoagulant, because you will see he has a high history in a cardiovascular event. And finally, he wants to change. I asked him to change before, he refused, and now he wants to change. So it's a good reason also. So you can see his history, medical history, with major depression, burnout, high cardiovascular, frequent cardiovascular events. So particularly myocardial infection, diabetes, dyslipidemia, and for his antiretroviral history, atripla is his first therapy. And he started in January 2009, and he was consistently undetectable. And we have just genotypic testing before he started his antiretroviral therapy, and he was sensitive to all heart. And actually, you can see his last result before switch. He was undetectable, and he has high CD4 cell count with a relatively preserved renal function, and also he's still diabetic. So you can see on the left is polypharmacy. It's relatively frequent with this patient and around 60. And when I discuss this case with the pharmacists of my clinic, and we work very closely together for this kind of cases, there is a possible interaction with rivaroxaban, is anticoagulant, and efavirenz. So efavirenz decreases the plasma concentration of rivaroxaban. Also, we check that there is possible interaction between quetiapine and efavirenz. So if we stop efavirenz, there is a risk of increasing a bit the doses of the concentration of quetiapine. Also with the same problem with bisoprolol and efavirenz for his blood pressure. I want to avoid abacavir given his past cardiovascular history. I want to avoid also cobicistat and protease inhibitor due to their possible metabolic effect. And I want to avoid rilpivirine because of the drug-drug interaction with pantoprazole. And you know, polypharmacy is a major problem, actually, because of drug-drug interaction. And possibly, you know, this very interesting data for the Netherlands cohort, Athena cohort. And what was interesting with this, so they have data for more than 10,000 HIV-infected patients, and they explain that possibly in 2030, if you take 400 patients, you will have almost 40% of them who will have major drug-drug interaction between their antiretroviral therapy and the other treatment. Most of them will be with a polypharmacy. So for him, I had several choices. I select just 4 choices. I can use raltegravir HD, so 2 pills a day plus TDF FTC. Few drug-drug interaction, no DDI with metformin, metabolic safe, but 3 pills 1 daily. I can use also dolutegravir with TDF FTC, metabolic safe, high genetic barrier with dolutegravir, 2 tabs once daily, but possible, yes, drug-drug interaction with metformin, but really manageable. I can use also bictegravir FTAF, 1 tab daily, metabolic safe, so the same thing, high genetic barrier, comparable to dolutegravir. With TAF, we can reduce bone and renal toxicity, less DDI with metformin, but actually limited access in Quebec because it's not yet reimbursed by RAMQ. Also, I can use doravirine TDF 3TC, 1 tab daily, metabolic safe, lipid neutral due to doravirine with a good effect on lipid with TDF. Tolerability profile, so for sure I could have problem with the renal function of my patient. No DDI with metformin, but also limited access because no reimbursement by RAMQ. So I just want to highlight 2 things that are important for this patient, and Alex discussed that with you before, is when we compare in the naive patient doravirine-based regimen with efavirenz-based regimen, is really the favorable neuropsychiatric profile superior with a doravirine-based regimen, so that it could be very interesting for my patients. And also the effect of doravirine, like a lipid neutral effect, which could be also very interesting, is this in the context of this patient with a high cardiovascular history. So I didn't give you the answer what we choose because I have to see him next week, and possible we will discuss that during the question period. You have possible ideas for these patients. So the second case will be to switch for a more neutral combination of art. So it is another patient. I followed him just recently. He was switched from another colleague who will get retired soon. So he has several comorbidities: alcoholism, anosmia, eczema, chronic constipation. He is undetectable since 1995. You will see with an important history of antiretroviral therapy. And he was recently diagnosed with Helicobacter pylori. And actually, he is on tenofovir, rilpivirine, and dolutegravir. He is undetectable, and he has a relatively preserved CD4 cell count. So you can see on the left his therapeutic history. So he has several combination antiretroviral treatment, and it changed due to DDI intolerance, due to virologic escape, virologic failure, nephrolithiasis. So really, and you can see in this genotype, he has more resistance in the protease inhibitor. So, and otherwise, he is not too bad. So the problem is he has to be treated for his Helicobacter pylori, and you know that he has to take high doses of pantoprazole, and there is a huge drug-drug interaction with rilpivirine. So what is interesting, can we think about doravirine? I think doravirine is interesting because doravirine is relatively neutral for drug-drug interaction. It's not a real inducer or blocker, and it has so minimal effect on the PK of other drugs. And you can see also on this slide that it is very minimally affected by other drugs, and particularly there is no drug-drug interaction with the pantoprazole and other in this class. So that's really interesting for my patients. So finally, we decided to switch for only rilpivirine for doravirine 100 mg QD, and we asked RAMQ, and we have relatively quick access with patient d'exception. He agreed also to stop alcohol during the antibiotic treatment to avoid the antabuse effect. And finally, after his treatment for Helicobacter pylori, he preferred to stay on doravirine, so tenofovir, doravirine, dolutegravir, because he has also no food restriction. So you can tell me, okay, but it's just one case. What is interesting, it was presented during the last CROI. The people, the team who is responsible, you know, for the website HIV drug-drug interaction, they presented the queries and the global search they have on the website, and you can see that for you have a lot of queries from clinicians or other healthcare providers for pantoprazole or omeprazole. So it seems to be a very frequent, common problem in our HIV practice. Also, what is interesting, it was just published 1 month ago from a French colleague, and they take, you know, like a retrospective cohort study. So it was patients living with HIV, above 65 years old, you know, almost 9,000, and they receive a combination of ART in 2016. And they verify if they had drug-drug interaction. So they take the definition, drug-drug interaction, on the SEB website. It was red flag. You don't have to use the medics concomitantly. And what they show that you can see in red that for the integrase inhibitor, the major problem you could have is with cobicistat and elvitegravir. For the PI protease inhibitor, for sure, most of them are boosted, so you will have frequent drug-drug interaction. And for NNRTI, the only problem will be with rilpivirine. And what was interesting also is they tried to evaluate the increase of cost due to DDI when the patient had DDI, and the increase of cost was $2,600 per year. So I presented at the beginning the challenge with NNRTI use, and finally, doravirine could be an answer. I will be very quick. So because of its resistance profile, because a better tolerability, neutral lipid profile, few drug-drug interaction, no baseline HIV RNA cutoff, and no food effects. So my conclusions, Possibly, yes. I think doravirine may be the answer to my current patient needs for heart, not for all, but for a lot of my actual current needs. And for sure, I think it looks like an similar integrase inhibitor. So it could be interesting, but particularly if I can't use integrase inhibitor. But however, we need long-term data with doravirine. And we need to see direct comparison with head-to-head comparison with integrase inhibitor. For sure, so I want to know, so the practice will let us know if we can use it sometimes in place of an integrase inhibitor. And of course, we have no data on conception or during pregnancy actually. Thank you for your attention.
So thank you, Bertrand. We've sort of kind of gone through doravirine and the evidence base behind it, as well as some of the practical situations where we might consider its use in sort of a current Canadian context. Over the course of the last half hour of the session, we want to kind of move away from what's currently available and talk a little bit more about what I personally think is super exciting, looking at the development program that is currently moving forward. We have Kathleen Squires, who's the head, the global director for scientific affairs for HIV, who's come from Kenilworth to tell us a bit about MK8591, which is now in development.
Thank you, Alex. Okay. So as Alex said, I do work at Merck Research Labs now. I've been there for about 1.5 years, and I am the global director for HIV scientific affairs within Merck Research Labs. I'm also a professor of medicine at Thomas Jefferson University in Philadelphia, and I still do see patients. My practice is now exclusively HIV, but do see patients at Jefferson on a weekly basis when I'm in town. Okay, so let's get started here. That's my conflict of interest, which I've already told you about. Okay, so you are probably aware that Merck has worked in the HIV field for approximately the last 30 years and will continue to work in that field as long as feels that there are unmet needs for our patients. So in that spirit, the drug that is now in clinical development and in clinical trials, and I will tell you about that at the end, is a drug which is called MK8591. And it is a nucleoside reverse transcriptase translocation inhibitor, so we call it an NNRTI, and I will explain a little bit more of the mechanism of action to you in a moment. And we feel that it has unique properties that may lead to important advances in antiretroviral therapy. And so you can see these kind of 5 buckets here of the properties that we think are of interest and that would be helpful in terms of putting together novel regimens. So the drug does have high potency, and again, I'm going to tell you a little bit about each one of these areas. It does have a strong resistance profile. To date, a good safety profile, and it certainly is a member of a class that we know a lot about that has literally been used throughout the past almost 25 years now. It does have a long half-life, and it has favorable tissue distribution. So what's listed below that are what we think we could achieve with the use of this agent. We think it would be potential to anchor a 2-drug treatment regimen and perhaps have the ability to rescue patients who have developed resistance to other HIV medications. It does avoid the use of other NNRTIs, specifically tenofovir and abacavir, agents that are common to most HIV regimens, and these drugs do have some long-term toxicities. It can be administered orally once daily and with less frequent dosing, either orally or parenterally, as a component of a treatment regimen. Right now it is being explored as a once daily regimen, but it certainly, because of its long half-life, could perhaps be used less frequently than once a day. And we believe, this last one is aspirational at the present time, that it might have a unique potential to reduce persistent replication of HIV chronic of HIV and chronic immune activation and inflammation. Now, again, that's something that we need to show or to demonstrate. So this is just the chemical structure. I'm actually going to switch to the next one. This is the chemical structure of the agent. It is the first in class of the NNRTI agents. As I said, it inhibits HIV through multiple mechanisms. It does have potent antiviral activity. Here you can see that the PBMC EC50 is 0.2 nanomolar with broad subtype and mutant coverage. So it is active against HIV-1, HIV-2, and multi-drug resistant strains. It is in vitro additive with respect to antiviral potency with 15 FDA-approved antiviral agents, including lamivudine, emtricitabine, and tenofovir. It has no or weak inhibition of human DNA polymerases alpha, beta, and gamma, so we don't feel that there would be any potential here for mitochondrial toxicity. And I'm going to tell you about the phase 2 study, so I won't spend any more time there. This is just a depiction of mechanism of action. I won't spend a lot of time on this, but it's kind of in a cartoon demonstrating why MK-8591 acts in a different way than a regular NRTI. So if you look at the top panel there, it's normal HIV replication, whereas you know HIV is an RNA virus and we need to make a DNA template of it. And this is demonstrating what reverse transcriptase is doing in terms of building a DNA chain from the RNA template. In the second panel here, it demonstrates the NNRTI single mechanism of action, whereas you know the nucleoside analog is incorporated into the growing DNA chain and affects chain termination. What happens with MK-8591, and it has multiple mechanisms of action, as it is incorporated into the chain because of its ethynyl group, it creates a very tight bond with the reverse transcriptase and therefore blocks translocation. So by blocking translocation, it is also an immediate chain terminator. If by some chance translocation does occur, then because of the altered structure that has occurred because of the incorporation of MK-8591 into the chain, you can't get any further transcription, and so it undergoes or achieves what is called delayed transcription as well. So it does work by multiple mechanisms of actions, and probably this is one of the reasons for its potency. The other aspect is that it does have a long half-life, and this is a little cartoon to describe that. So you see MK-8591 going into a cell and being phosphorylated within the cell. Because of the fluorine group, the fluorine that is on the chain, that inhibits the breakdown or metabolism of MK-8591 by adenosine deaminase, and so the half-life within the cell of the triphosphorylated form is anywhere from about 79 to 125 or 128 hours. It very slowly metabolizes back to its parent form. It can diffuse out of the cell and into another cell where it can be triphosphorylated again. So the difference in the mechanism of action and this long half-life, we feel, does give it some of its unique attributes. So I'm going to go on and tell you a little bit about some of the in vitro data that has been developed here. So in this slide, you can see within the table that you have MK-8591 and a number of other reverse transcriptase inhibitors listed there. And then you can see that what is looked at here is the IC50 for these particular compounds for wild type virus for all of the nucleoside analogs, and for the case of MK-8591 against M184I or M184V. So if you look at the IC50 for MK8591 against wild type, you see it's 0.2 nanomolar for both of these lab isolates. For the two M184V mutations, you can see that there's about a 10-fold increase up to 1.0 or 1.6, depending on which of those mutations you look at. And when you compare that in terms of the IC50 against wild type for the other nucleoside analogs, you can see that there's at least a 10-fold or greater change, meaning that MK8591 has greater activity against wild type as well as at least the M184V mutation here. And then on the graph here, you can see the percent inhibition, and the MK8591, which is depicted in the green, you see the shift to the left. On this slide, this just demonstrates that for all of the subtypes that are listed, HIV-1 subtypes that are listed here, that for MK8591, the activity is very similar across all these subtypes. So this virus should be active against all subtypes of HIV. Now this is a little bit of a complicated slide, but I'll walk you through it. So you can see on the x-axis that we have the calculated PBMC IC50 in nanomolar for all of the viruses that are listed across the y-axis, which starting with wild-type virus and then viruses that contain an increasing number of NNRTI resistance mutations. What the dots depict are separate viral isolates, and they are color-coded by what they have been exposed to. So you can see MK8591 is in that kind of teal color, 3TC, TAF, and AZT. What I can't really see there, but there is a dotted green line there, and that is the IC50 for TAF. So what you can see is that for all of these viruses, MK8591 has much greater activity against these viruses, regardless of the mutations, than any of the other nucleoside analogs that are listed here, and that all of those, the IC50 is less than the IC50 for wild type for TAF. All right, so you might say, well, what is the, what kind of resistance do you see with MK8591? And in serial passages, you can see the M184V or I mutation emerge. So the question is, can MK8591 actually suppress this, resistance mutation? So this is a study that was done in macaque that was infected with a SIV, and then the macaque was treated with 3TC. And you can send, and each one of those dots here are viral isolates, and you can see that the a macaque was infected with wild-type virus that then developed an M184V mutation with serial treatment with 3TC. Depicted in the green are two different doses given at weekly intervals of MK8591, and you can see that you get about a 4-log decline in viral load, which persists until the drug the level of the drug has decreased, and then you see viral load come back up, and what comes back up is the M184V. So even in the presence of the M184V mutation, the levels of this drug that are achievable can completely suppress the M184V mutation. This is to speak to the issue of the drug being concentrated or enriched in lymphoid tissues. This is a rat that has been radio-labeled, and at the bottom here you can see the red arrows are pointing to lymph nodes, and the kind of absence there is where the radio label is, and in the little table there you can see that the drug is actually concentrated over 24 hours after it has been administered. So we do know that the drug gets concentrated in lymphoid tissue. Whether that will have an effect on persistent infection and on inflammation is something that we are going to be exploring as the drug is developed. The other thing that has been of interest is whether MK-8591, because it has such great potency, would work in a prevention type of model. So this is a study that was done in macaques. These macaques were rectally challenged with a highly pathogenic strain of HIV, and they were treated on a weekly basis with MK-8591. In brief, up to doses down to 0.43 milligrams per kilogram, the macaques were totally protected against a HIV infection, as opposed to the macaques that received placebo, that you can see that they all became infected with less than 5 rectal challenges of HIV. And so we feel, or when the calculations are done, this drug is protective down to a dose of 0.1 milligrams per kilogram. So it is going to be looked at in terms of its utility in HIV prevention as well. Okay, now moving into humans. This is the phase 1 study, dose ranging study looking at the antiviral effect of MK-8591 with doses from 0.5 milligrams up to 30 milligrams. This is one dose that's been given, and the patients were then followed for either out to 7 or to 10 days and then started on antiretroviral therapy. And what you can see is across all these dosing levels is that you do get a significant drop in viral load of at least about 1.5 logs. That's in the top panel. In the bottom panel is looking at the intracellular or the PBMC concentrations of the triphosphate, and basically what is demonstrated there is that you see potent antiviral activity down to 0.5 milligrams per kilogram. This is now looking at daily dosing of MK-8591. There were 3 different doses given there, 0.25 milligrams, 0.75 milligrams, and 5 milligrams. These are looking at the plasma levels here. They all were above the plasma level that is considered to be therapeutic within 24 hours. And you can see for the patients, none of the patients that were in this trial came off of the study because of any drug-associated AEs. This is now looking at the intracellular concentrations for these 3 different doses. You can see that we achieve levels within the PBMCs, again, within 24 hours of the first dose, and all of them down to 0.25 milligrams or above the therapeutic threshold. Okay, so I'm just going to end up by saying where we are going with MK-8591. I won't necessarily read through this slide. The slide really talks to the issue of why we would think about combining MK-8591 with doravirine. What I'm showing you here on this next slide is to try and really understand whether this combination would have good activity. This is an in vitro experiment where viral isolates were exposed to the combination of doravirine MK-8591, doravirine and 3-TC, dolutegravir 3-TC, and bictegravir and 3-TC. I won't go through all of the other ones. Some of these would obviously never be given together clinically, but for doravirine and MK-8591, by the time you get to 4 times or 8 times the EC50, which is achievable in plasma and PBMCs, you can see that the virus was completely suppressed, that there was no breakthrough throughout the course of this experiment. So based on this, as well as a number of other lines of evidence, the phase 2 study looking at the daily combination of doravirine and MK-8591 is ongoing right now. This is the study design. So these are treatment-naive patients. You can see the inclusion criteria. And they were randomized to receive either 3 doses of MK8591. You can see 0.25 milligrams, 0.75 milligrams, or 2.25 milligrams. For the first 24 weeks, they were also given doravirine and 3TC. And the control arm throughout is the co-formulation of doravirine, 3TC, and tenofovir. For those patients, by week 24, if their viral load is less than 50 copies, or at any time along and up to 48 weeks for an individual patient when their viral load is less than 50, they then have the 3TC dropped, and they remain on the 3 different doses of MK8591 plus doravirine, and then the control arm stays on the co-formulation. At week 48, a decision will be made about the dosing or the dose that will be then taken forward into phase 3 studies. The study is fully enrolled. All patients are past week 24 at this point. They are continued to be followed, and we will be presenting the week 24 results at one of the conferences later this year. So that's kind of where we are with this drug at the moment. I've pointed out to you that there are other ways that, because of the attributes of this drug, that it could perhaps be studied, and we are pursuing those lines as well. So I think that was my last slide, and I'm going to end there, and thank you for your attention.
So it's difficult to say, but I can ask what would be the clinical perspective for the MK8591. So it's a bit difficult because we don't have a lot of data. So I try just to imagine how we can use it. Because finally, despite an extraordinary efficacy of our antiretroviral combination, HIV therapy can still be improved. There is still room for improvement. And I think it could be interesting because it's like a new class with a very low dose, with on-daily administration, a new dual therapy, so it will be combined for the first step with doravirine. What was just presented seems to have a short-term safety, interesting short-term safety, interesting tolerability also, with high probability of very few drug-drug interaction because it will not be a cytochrome inducer or blocker. So for sure, it will be interesting characteristic in our daily practice. Also, for the patient with a long and complex treatment history, we have a lot of people like that in our clinic. We need agents with no cross-resistance to existing classes. So for sure, possibly it's a target population, but it's very needy. There is potential for a high barrier to the development of resistance with this new molecule. And also, I have some of my patients, they ask me to decrease the number of pills in their treatment regimen. And for sure, to have a new combination of doravirine with MK591 in 1 pill per day could be interesting also to try to simplify almost the number of pills. In the second step, it will be interesting because it will be developed as a long-acting agent, and we know actually because there is other long-acting in development, and we will have them a bit more quickly. So it's interesting because we have treatment fatigue, we have pills fatigue with some of our patients, and we know this poor adherence in chronic condition. For sure, it will be attractive for people with pill fatigue. Possibly, it will be better to provide a better protection for health privacy. You don't have to add yourself to take your treatment every day. And it could have a positive impact also on HIV-related stigma. And with this new characteristic of the MK591, of course, it will be an interesting for this new family of long-acting agents.
So thank you, Bertrand and Kate. We're just going to finish off here. Thank you for all of you who have stayed. Just To sort of summarize, 8591 for me is very exciting, actually. And when I heard about this probably a couple years ago, nobody actually mentioned the fact that this was actually discovered in soy sauce. So that's why it's actually licensed from Yamasa, because for all of us, most of you probably eat sushi. So you go to the sushi restaurant and you see the bottles. There's like a low sodium one, which is like the green bottle, and then the regular one that's the red bottle. That's Yamasa soy sauce. So every time you're basically dipping your sushi, which you're not supposed to do according to the sushi chefs, you're actually having a little teeny tiny dose of 8591 in your system as a result. So just as an FYI. So this is, maybe it's just my Asian thing, right? Because like it's got this soy sauce heritage, but I just think it's just really, really cool from a scientific perspective. But from a practical perspective, there's a lot of versatility that the drug potentially offers. And again, we're all just sort of speculating at this point. We don't necessarily know what's going to be developed. But it kind of changes our thinking around this whole concept of an anchor drug. Like we've always thought of the third agent, whether that's a PI or an NNRTI or an integrase, kind of being the drug that kind of does the heavy lifting, and then the NRTI sort of being the backbone. And here we're kind of flipping that sort of 180 and thinking about the 8591 as being the anchor drug, and doravirine, which has already been shown as at least an adequate anchor drug compared to, say, boosted darunavir and efavirenz, now being sort of the support drug. So again, for me as a simple clinician with a simple brain, I sort of think about that and think, well, maybe that's going to be a potent combination that might have some utility. The fact that it basically is active despite any type of pre-existing nucleotide resistance is also extremely exciting, and we're hopeful that Merck will be proactive in terms of their clinical trial program and allowing potentially some patients with pre-existing resistance into their clinical trials. And as Bertrand mentioned, it can be formulated potentially as a long-acting agent for therapy and for PrEP. If you can imagine, for example, again, just speculating, a long-acting sort of implantable depot under the skin or something like that that could conceivably prevent for a year. Right, so this is the type of technology that was inconceivable even like 2 or 3 years ago. So there are some long-term questions. Obviously, we don't have any real-world data. We don't know how safe it is going to be and what the resistance profile is going to be in long-term settings, the commercial viability of it, and so on. So it's not, it's not quite ready, but it's exciting. And so I just want to finish by saying that I think it's really an exciting time in HIV therapeutics. I think probably about 3 years ago when the data around bictegravir was sort of coming out and we had sort of single tablet protease inhibitors, certainly here in Saskatchewan. The thought was just we're going to put everybody on, single tablet protease inhibitor, and that would pretty much be that. And, now we have all kinds of really cool stuff coming down the pipe. We have broadly neutralizing antibodies, capsid inhibitors, long-acting formulations, both sort of intramuscular, subcutaneous, possibly, again, like depot formulations, as well as multiple single-tablet options, both 2 and 3 drug options. We didn't even conceive, 3 or 4 years ago that this was going to be what it was all going to look like. And so it's hard to know how all of this is going to go. I think a lot of us are optimistic, but you never know quite how it's going to go. But the potential of being able to envision a future as a clinician where I can, potentially offer to a newly diagnosed person the opportunity to take a pill once a day, maybe to, take an intramuscular injection once every 2 months, maybe an IV infusion once every 6 months, or even possibly like some sort of like a depot formulation or something under the skin like once a year. That's kind of crazy, actually. And so it really is an exciting time in HIV therapeutics, and that's not really Merck specific. All the companies are developing neat and cool compounds, and we're really excited and looking forward to ways that we can potentially utilize some of these compounds, both for high-functioning patients and for patients that may be more marginalized and disadvantaged, which is obviously a tremendous issue here in our province of Saskatchewan. So to finalize, we're pretty much done here. I just want to highlight that Merck's kind of been in the game for a long time. I mean, in 1996, there was this thing, I don't know what this is called, Crixivan. I think I was just entering university at that point in time and kind of clueless. And then 1998, actually, Merck discovered efavirenz. So kudos to Merck and to the rest of the companies, who have been in the game for a long time and recognize that HIV therapeutic development and cure research remains extremely important and valuable going forward. And we're hopeful that, maybe 5 years from now or maybe 10 years from now when we're back in Saskatoon or in Saskatchewan, we might be actually viably talking about some of these things as realities as opposed to just simply speculating. So thank you all for attending. I want to thank my co-presenters Bertrand and Kate for their excellent work, and thank you all for attending, and thank you to Merck for sponsoring this talk and lunch. Are there any questions? So I don't know if there's any questions at all. If there probably isn't, but anybody? If not, JP. Yeah.
As the half-life is very long, is there no accumulation over time? How do you deal with potential accumulation? If the pill is taken daily and the half-life is 2 or 3 days, how do you go through?
So the accumulation is no more than 2 times that, so it's very, very small in terms of accumulation. What we are looking at, the other question obviously is the tail, so to speak, and we certainly are looking at that issue and have experiments designed, or not experiments, but following patients to see what the tail and the dynamics of the tail are. So I can't give you all of those results at the moment, but we are certainly looking at that.
Thank you.
Any other questions from anyone in the audience? Then thank you again for your participation and attendance today, and for coming to Saskatchewan and supporting the importance of continuing the fight with HIV here in this province. Cheers.